Today, I'm joined by Dr. Rachael Haverland, a powerhouse in endometriosis excision surgery, and someone who is fiercely committed to giving patients real answers and real hope. We're talking about everything from Appendix Endo to early intervention, gaslighting in medicine, and what true shared decision making looks like in the OR. Dr. Haverland is one of those rare surgeons who sees the full picture and listens deeply. Let's dive in. Welcome back, everyone. I am with an amazing guest today. I have another wonderful endometriosis excision surgeon and just incredible person, Dr. Rachael Haverland.
Ginger, thank you for having me. I've been looking forward to this for the last few months since we met at the Endo Summit. So I'm really excited about today.
Well,
Anybody that gets me talking about endo and advocacy, I could speak for hours. So I'm really excited to be here today.
Thank you. Thank you for being here. I have been kind of chasing you down. I will stop short of saying stalking since I saw you at a distance at the Endo Summit in a previous year. And then we got to connect this year and I'm so excited.
Yeah, that was great. The Endo Summit's really good for that, bringing all the different specialties together, including patients. And anyways, I was the lucky one. That made me excited.
All right, everybody. As you well know, I want you to learn about our guests before we launch into our chat. So here we go. This is our bragging moment. Dr. Rachael Haverland is a board-certified endometriosis specialist based in Dallas, Texas. As a physician fellowship trained at the Mayo Clinic under the pioneers of endometriosis surgery, she has extensive experience in optimizing gynecologic surgery with minimally invasive techniques. Yes, yes, yes. She believes in a holistic, also yes, well-rounded approach for best outcomes for endo treatment. Dr. Haverland specifically holds a focus practice designation in MIGS, minimally invasive gynecologic surgery, through the governing board of OBGYN, putting her at the highest tier for specialists in gynecologic surgery, which is important for our listeners because they may not know that's important for surgeons to have. Additionally, she's submitted hours of videos through a vetting process called iCareBetter, which she's been verified with expertise in endo excision by the most experienced endometriosis surgeons in the country. Recently, she has become a master surgeon through the Center of Excellence at multiple hospitals in the DFW, the Dallas-Fort Worth area. With her membership to a multitude of national professional organizations, as well as her publications in numerous academic journals, y'all can feel confident that she is attuned to the latest, most up-to-date approaches in the treatment of endometriosis. Welcome.
Thank you. Thank you very much. I think that just means I'm a glutton for training. I just keep training, punishment, training some more. But it is very rewarding. So thank you for that, Ginger.
Yeah, absolutely, Rachael. I think that is like requisite for, being in healthcare, although that doesn't feel like a requisite because so many patients are seeing so many practitioners before they get to find actual care and relief. And that's why we're here.
It is. And, one of the goals of my practice and my career is I like to decrease the amount of time that it takes for patients to get appropriate care and to be able to treat women earlier, like trying to catch them when they're in their teens and their 20s, not when they're in their 30s, because those 10 years matter. 10 years of chronic damage, 10 years of effects on the nerves and the pelvic floor. And it just makes it harder and harder to reverse that sequela the longer we let it go. So one of my goals, I'll get off my soapbox in a second, but I mean, advocacy is the way to do that. Trying to teach more providers about, how to treat endometriosis, where to direct them for appropriate care, and just learning more about it. Like not waiting until they've been having symptoms for 10 years to ever hear the word endometriosis. So hopefully we'll get there.
Yeah, I think you make a really good point about, anyone who has been with someone with endo, has endo, knows anything about endo, has heard about the delay in diagnosis. And then what happens is there's also, it's not the nuanced or softer side, but we often think of the mental health perspective
Sure.
as kind of the softer side of, oh, well, I'll get to that later. Let me get to the physical stuff first. But when someone has delayed care, 1 year, 2 years, 7 years, 10
Yeah.
years,
Yeah.
2 decades, there's such a mental health toll and burden that goes with that, that does end up presenting itself physically eventually and
100%.
exacerbating
Yeah.
everything.
And we know that our mental health affects us physically, even if
Yeah.
we try not to let it. It's impossible not to.
Yeah.
When you're hurting all the time, it's almost impossible not to be frustrated and to be sad about it, or not to have any options for treatment. And
Mhm.
so I agree. The mental health side effects very much connects to the physical components, not just with endo, but really any chronic disease.
Mhm. Yeah. So, what share with our listeners a little bit about your background and what led you to focus on endometriosis, because that is a very unique specialty of a specialty,
Yeah.
pathway.
I always knew I wanted to be in women's health. So when I first went to medical school, I actually sort of thought I wanted to be a general surgeon, and then I went into my OBGYN rotation, and I just knew that this is where I was meant to be. I wanted to advocate for these women. I love the women's health aspect. But I was lucky in my residency that they also had a MIGS fellowship. Dr. Michael Hibner was our MIGS, the head of the MIGS department there, and he was starting to do or had been doing endometriosis excision. And so I was exposed to this early. And I realized this is a very like this population of women weren't being heard and nobody was speaking for them. And it called me. And I'm so honored to get to be in this space and take care of these, these women that I see and my patients. But it was very cool. Once I got there, just a light bulb went off. This is where I'm meant to be. These are the people I need to advocate for. These are the patients who need help because they need a voice. And so I was in Phoenix at the time for my residency, and then I did a 2-year fellowship at Mayo. And that's where Megan Watson is and Javier Magrina. And,
Yeah.
They were also at the pioneers at the forefront of endometriosis treatment and excision. And it was very special to be able to be there during that time to learn with them and learn from them. And then my family is from Texas and from Dallas. So we came back home and, I found that it's not just DFW. It is all of Texas. It's really the whole country. We need more specialists focused on endometriosis. There is not a lack of patients. When it affects 1 in 9, probably even 1 in 8 women in the country, there's a lot of treatment that needs to be had, even outside of surgery. But a multidisciplinary
Yeah.
approach, just trying to diagnose it, giving people answers, and then giving them all of their options for treatment. I'm a surgeon. I see a ton of benefit through surgery, but there's a lot of options even outside of surgery that people can start, like steps people can start taking before they get to feel comfortable with surgery, or if they've already had surgery and still aren't seeing the benefits yet, knowing that there's other treatment plans to implement to get the best outcome.
Yeah. And so, just kind of to quantify that for everyone listening. So, if you are maybe you're PT listening or an OT, or maybe you're not in women's health, but you know somebody in your family and you're in healthcare, if a patient, if a provider is seeing 20 patients a week or 30 patients a week as a therapist, right?
Right.
When you're spending the better part of an hour with them, that's, 20, 30, hopefully not 40 patients, or, oh my gosh, that's like burnout.
That is a lot.
Yeah. And if you are in women's health, okay, then they're 100% women. How many of those women per week do you see that someone, okay, multiple cases are going to have endo? And so when I look at, reflect on, my practice, it feels like I am literally referring people on a weekly basis.
Yes.
And so think of multiply that by thousands of therapists who can be screening for this, school nurses,
Yeah.
right? Anyone who has contact, with young girls,
Yeah.
and young
I
women.
give lectures to the pediatricians, through the hospital,
That's
not
wonderful.
just to try to tell them what to do, but to give them some more resources and some more guidance for these young women when if they start to have symptoms so early, just on next options and next steps, so that they don't get stuck in this just cogwheel of only hormones as the only option. which is not necessarily wrong, but it's not for everybody. And so it's really important to make sure that we can kind of treat them early with this multidisciplinary approach, even in the pediatric population. And so you're absolutely right. It does, physical therapists, dietitians, school nurses. That's a great one. I actually haven't even thought about that, but it's just, it's so important to spread awareness so that it's at least in the back of your mind. And if you don't know, well, then you can always refer the patient to get a little bit more detailed evaluation.
Yeah, absolutely. And that can happen across multiple levels. If we just run with the example of a school nurse that sees a young patient with, a young lady with period pain or constant gastrointestinal issues that may be cyclical,
Or even like GI nausea, vomiting. A lot of my young women, that's how they present. They don't really even see the dysmenorrhea or the pain with their period. A lot of it is just GI, like nausea, vomiting with their cycle, but not necessarily pelvic pain specifically. But it's just kind of shows you how endometriosis is very much a whole body disease, a whole body inflammation, not just a pelvic disease.
Yeah, I had a recent case where, and this is why investigation and diving a little deeper is important, because she came in as a direct referral, as a kind of a last resort. She'd been to a lot of different practitioners, and she had missed an appointment because she was in the ER, the ED.
Yeah.
She had to go to the ER. And when I came in, when she came in, she's like, "So sorry, I missed my appointment." I'm like, "Oh, let's sit down and talk about what happened." She's like, "Oh, it's unrelated." I'm like, "Well, tell me a little bit about what happened." And it turns out she was in the ER for shortness of breath and pain with breathing, with respiration.
Yeah.
To which she was told, "Take a Tylenol, go home. You're just having an anxiety, panic attack," because she thought she was, having a heart attack or something. And this is a teenager, a young adult.
Yeah.
And then you know where we're going with this next, Rachel. We had to have the discussion of that is related to your symptoms. And let's put all the pieces of this together, which became a catalyst to go, okay, that's when the family was like, we can't keep doing this, because every ED visit could be $8,000 if they run a few tests.
Easy.
And that became the catalyst, finally piecing it together, because, not to blame the pracs in the ED or something, but they're not going to be able, we know, they're not going to be able to diagnose that. They don't diagnose,
the job of the ER is to decide if you're sick enough to be in the hospital or if you're safe enough to go home. And that they're not specialized outside of that.
Yeah. So that became the catalyst. So putting, all those symptoms together at the school nurse level may mean, and then she was in my office next, right?
Yeah.
So it may mean that the school nurse is like, why don't you, or the folks in the ED, why, if they had that education to identify the signs of endo, to go, oh, you got an appointment next Tuesday with your pelvic PT, talk to them about that, instead of it being you separate, right? And then she comes in, she doesn't think it's related, but it is.
It is. Yeah,
because
whole
you're
body
not going to get into a surgeon like right away, but you could see the pelvic PT who could help you manage the pain. And we went over respiratory stuff.
Start working on diet changes. Start working on, sometimes I implement or try, it's hard to implement everything at one time, but really that's when you get the best outcomes. If you could do some sort of yoga, meditation, pelvic floor physical therapy, it really does make a difference, but it is a little daunting. I think at first, when you see all of the options, for treatment. But, going back to this, how endometriosis affects all these different organ systems. I read a study the other day because I was making a PowerPoint for a presentation, and it listed endometriosis, the most common symptom, as fatigue. And at first I read this and I was kind of annoyed because I was like, this does not help me. Everybody has fatigue, but it makes so much sense. Your body is chronically fighting this disease, all of this inflammation, and it gives you no extra energy for your daily functioning. It's just trying to get by, and it's fighting constantly. And so it makes sense that fatigue is so common in this population, but it can be something so simple, so minute that you may not think is related, but it absolutely can be. GI symptoms, bladder symptoms, pain with intercourse. Sometimes I see women, that is their only symptom of endo, is that they have a hard time having, penetrative intercourse with their partner. And, they love them. They feel safe. They're in a safe relationship. And, despite physical therapy, or maybe they haven't tried physical therapy, but a lot of times they can't get to the point where they can tolerate it. And it presents in so many different ways. Even I, who only does endometriosis, am still surprised with how it presents sometimes. It keeps me on my toes. That is for sure.
Yeah, because it's going full circle back to the beginning of the discussion, because it is a whole body experience and disease, not this just a
not just in the
reproductive.
pelvis, affecting the reproductive organs. Yeah.
So speaking of all of the strange and wild symptoms that can occur, we talked about earlier, before we press record, actually back at the Endo Summit, we talked about discussing the appendix and endometriosis.
Yeah.
So shed a little bit of light for our listeners on this topic, because, as I do prehab, for patients going in, it's one of the things we discuss, because they will come back and be surprised. They could be surprised that, oh, well, they took my appendix at the same time.
Yeah.
So shed some light on that for us. Maybe like your first encounter with a case of appendix endo, and how it shifted your understanding of the disease.
Sure.
And what you look for.
Yeah. So, even in training, we were seeing endometriosis on the appendix. It is the first organ outside of the pelvis that endometriosis is most common to spread. And we think it's because of sort of how the lymph flows in the pelvis. It's kind of in a counterclockwise way. It almost spreads like cancer, even though it's not cancer. We think that may be one of the modalities that it spreads. Also, if you have an endometrioma or more endometriosis on your right side, which is in close proximity to that appendix, it also increases your risk of having endometriosis on the appendix. On every patient that I take to surgery, I talk to them about this. I'm like, hey, go through all this, the surgery discussion. We're going to look at your diaphragm. We're going to look at your gallbladder, your stomach, the liver. But I always counsel them on a possible appendectomy. Like this is more common. Women with stage 3 or 4 disease have about a 30% chance of having endometriosis in their appendix. Sometimes you can see it, and sometimes it's very obvious. In fact, on Monday, I had 2 patients with deep endometriosis on their appendix. And then I'll go like a few weeks and I won't see one. But the endometriosis on the appendix almost looks like appendicitis. You can see the tip of the appendix starting to curl, or it gets red and inflamed. Sometimes you do see just those classic implants of endo, those little black, brown implants, but it also can have the atypical appearance of endo as well, which is the clear vesicular or like raised lesions. The appendix is a very delicate structure because it's very thin. And so it's not a place where you can excise endometriosis from and keep the appendix. It's kind of an all or none, because if you take out a portion of the appendix without taking all of it, you just have a much higher risk of complications or appendicitis down the road. So when you see endometriosis on the appendix, you have to be a little aggressive in removing it. And people, it's nerve-wracking to take out organs, and people talk about, what is the benefit of the appendix? What does it do for us? They kind of relate it to the gallbladders. It's similar to the gallbladder and how it affects digestion. And so, it is important to have this discussion. I believe very strongly in patients' autonomy, women getting to make decisions for themselves. I want to tell them what my recommendations are, but I certainly don't ever want them to feel forced or pressured into doing something that they're not fully educated on or just don't feel comfortable. And so when it comes to the appendix, we talk about kind of where it came from. So we think that it is this vestigial organ that we used more, in the past when we're eating rocks and, sand and some of our food to help with digestion. But as we've, grown and changed, it doesn't have a lot of benefit. There is some evidence that it may help with some of the microbiome of the colon, maybe helping with some of the like IgA and other factors to help make sure that we have the good bacteria in the colon. That's not, it doesn't have great evidence behind it as far as like clinically proven, but I do talk to them about that. removing the appendix doesn't necessarily increase your risk of complications of surgery. I do give slightly different antibiotics during surgery, but again, I talked to them about it's not something I can excise from without removing the whole appendage, just because of the risk of going forward. But you can see the appendix sometimes is stuck down, like into stuck with the ovary, and there's this big adnexal mass, and it has the ovary, the fallopian tube, and the appendix stuck in there. And it's sometimes you don't know what you're going to get into, but it is relatively common with endometriosis, so we always make sure we bring it up in the discussion.
Yeah. So for listeners out there, it's no secret to them. I have a whole YouTube playlist on the fact that I have endometriosis, have had. And I'm also one of those unique individuals who had 2 appendectomies.
Oh, no. Mm-hmm. I do not know that.
Yeah. Yeah. I feel a little bit about like a unicorn, but I don't want that horn on my head.
No.
But I had that. And of course, at that time, one was actually, I was preschool aged.
Oh, wow.
When it started. And of course, at the time, it was in a rural hospital in a small area. They just made a big, not minimally invasive vertical incision.
Yeah,
because
that's so tough too to recover from.
Because you don't even know, you can't even describe pain if you're, 3 years old, right?
No.
But anyway, it happened again. And of course, they didn't biopsy things properly. So nothing got diagnosed properly. So that then delayed intervention even longer. But when I talk to patients about Appendix Endo, I can't not think about that unique situation where things could have been caught decades earlier.
Yes.
Yeah. If they would have just looked at it. And of course, I languished in a hospital on a
PCA.
Mm-hmm, yep, on a patient controlled pump for a couple of days because everybody was like, she's already had her appendix out. We have we have no idea what's going on.
So somebody finally believed you. I mean, this is kind of like the classic endometriosis story. You advocate and advocate and advocate until finally somebody listens and takes you seriously.
Mm-hmm. And I'm not a big person, and I'm also a PT, and so I value fitness, and for me, I work out, etc. But when you go into the ED and you're in severe pain, they don't know what you looked like. Yeah. They don't really pay attention to any of that. So I looked about 6 months pregnant already, but as a fit, smaller woman, that's not me. But that wasn't also registering. So by day 2, imagine what that looked like as I just continued to swell and stuff. So it was very uncomfortable. I was stuck in a rural hospital where it was just felt like too much pain to move. And so that's what it ended up getting kind of diagnosed as. But I have my spider sense, always goes up when I see these, right lower quadrant symptoms, just because of my own experience. I think the biggest thing that I took away from that is unfortunately more medical trauma, like from the gaslighting.
Absolutely.
Yeah.
And I see that so much. And it's so hard, especially being a medical professional. You're in this space. You literally know what's happening, and there's still nothing you can do about it. It's petrifying. It really is. And it's very humbling to be in that space, because you and I, we advocate for our patients and we want to be the voice for them. But it's scary to be in a place where you know exactly what's happening and there's still nothing you can do about it. And luckily, finally, you were taken seriously. But the trauma stays with you, and I see this in my patients. And I talk about, when I see patients, they're like, "Oh, your job must be very hard." I'm like, no, my job is actually very easy. I just listen and believe my patients. I mean, imagine that. And it is, it's not, breaking news. Your symptoms are real. This is not in your head. And then we just have to decide together what we're going to do about it. And I think that sometimes is all that my patients need to hear is just, okay, like I don't have to convince her that this is real, or convince her of how bad my pain is, or convince her of what I've gone through or what I've tried beforehand. She just believes me. And I think that we really need to try to spread that to other providers, not just in the hospitals, but really everywhere, because the women in general are less likely to be listened to, but especially young women, more likely to be considered histrionic or anxiety, or, this isn't real, or in your head, or just not, not taking you seriously. So really working on sort of changing that landscape.
Yeah. I will never forget, two providers coming in to the room. This was in the middle of the night, totally questionable, care, but came in the middle of the night and basically said, "There's nothing wrong with you." And the next morning they're like, "Yeah, okay, whatever. We'll do this. We'll do this scope, but we're not going to find anything." And of course, after the same surgeon treated me like that, he came back in the next day. Of course, they should have biopsied it to see what it actually was.
Sure.
But they just threw it in the appendicitis bin, and did apologize, actually, and
Good.
say, we've got 8 surgeons in the practice, and that covers nearly 80 years or whatever of collective practice or whatnot, and none of us have ever seen this happen ever before. So sorry, we didn't believe you.
Yeah. Did you feel better pretty quickly?
After?
Yeah. Or did it take a while, because you were probably infected at that point?
Yeah, I was. I had peritonitis.
Yeah.
So that took a while. It was probably more painful, the recovery, than it needed to be,
Yeah.
and I had lost other organs too as a result of this, because there were so many adhesions. And so they were ablating things. They were burning things.
Yeah.
And it just felt like all that did was light the whole fire of everything that was left there.
Yeah.
That hadn't been excised and hadn't been taken care of properly yet.
Right.
So in all those cases, I think that it took a lot longer to recover, which made me feel even more like I had no pain tolerance.
Right.
Even though I had 3 kids with pain, no pain meds. Right.
Yeah. Yeah.
I gave birth to 3 big-headed babies with no pain meds, but it still made me gaslight myself. Why is this recovery taking so long? This shouldn't be a big deal.
Why am I not 100%? Shouldn't I be back to baseline? Yeah.
Yeah. I even, checked myself out of the hospital, got home. I had tickets to go see Messiah at the National Cathedral, which was 6 hours away, and I was determined to go. So I got in the shower, got in the car, and drove to DC because that's how bad I had gaslit myself. This is not a big deal. You just had another appendix out. Get in the car and carry on with your life. Yeah.
Yeah.
So that's why, you always
you're an impressive woman. I don't think many people would be able to do that.
Yeah. I did. I was like, I don't need these pain meds. And so I didn't even take the pain meds.
Oh.
And that was a mistake. And And I actually
go ahead.
No. It was a lesson.
Yeah.
It was a lesson. It was a lesson. And I did not have the access to proper care. So it wasn't going to happen. I just couldn't have willed proper care to happen.
Yeah.
But you did the best with what you could. What could I have done better? Not gaslight myself after experiencing that kind of institutional betrayal where I was told, "Oh, you're just making this up. You're just a pain med seeker." Even though I'm like, no, I'm a women's health PT and I've given birth 3 times with no pain meds. I'm not making this up. So I could have treated myself kinder after that. Yeah. And I think that's a lesson for anyone with endo and anyone who treats women, with endo too. Yeah.
I agree with you. And the gaslighting is very weird when it is coming from yourself. My patients actually tell me this. I go over the risks of surgery with them the day before and in the morning of surgery, risk of bleeding or infection or, complications afterwards. And, even though I'm talking to them about scary things, they say, "Oh, okay, what if you don't find anything?" And they're not alone. It's almost everyone. Even though they were in the fetal position on the bathroom floor 2 days ago, today they may feel okay. They're like, well, maybe it's not real. Maybe it is in my head. You talk yourself down. You talk yourself out of it. And some of it is societal. We're supposed to be these, strong, independent women who we don't need anyone, which I think is also good. I'm very much of a feminist. But, you also have to to believe yourself and trust your instincts. You know your body better than anybody else. And I tell patients that, I know the science, I know the micro, biology behind endometriosis. I've studied it. I know the medications, but you know your body and you have to trust yourself. This is not in your head. It is in your pelvis. And this is what's causing your symptoms. The symptoms you're experiencing are not normal. And I think sometimes it does help when patients bring their family or their partner in with them to their visits, because they also do this to me sometimes when they're telling me their symptoms. They're like, oh, well, yes, last week, it was painful, but today it's not too bad. Like they kind of downplay some of the symptoms they're having, and their family or their husbands or their partners were like, no, this was terrible. I was petrified for you. You were screaming in bed and you couldn't move, or you couldn't get off the floor, or the amount of bleeding that you're having was, I was worried I needed to take you to the ER. Mm-hmm. They help kind of solidify some of the symptoms, because even patients who know there's something wrong, make a visit with me, know that there is, likely endometriosis or something else causing their symptoms. They downplay it a little bit because we don't want to be complainers. We don't want to cause a problem, and just trusting your instincts. And, I do the same thing. And if I were in your shoes, I'm not sure I would have done anything different, because it's just so hard to know, especially when you're in that environment and you're in a lot of pain. Sometimes your brain isn't, fully functioning. You don't have that clarity because you're just struggling to survive, or just to get through, or to next steps. And it's hard to see what next steps need to be to help advocate for yourself.
Yeah, you made a really good point about when you're in pain, you're not going to have that clarity that you think you would when you don't have that pain. It's similar to when you're doing, like I will do birth coaching, birth prep, like prepare to push, for moms. And I always have to get to this point, and I use myself as an example, not because it's a gold standard or something. It's because brains in pain don't act the same. And I tell them, I'm like, you need an advocate with you. And then I'll show them the evidence, when you're in pain, women who have constant support and no one leaves their side actually do better. Their birth outcomes are better. Their pain perception is less. It's like, don't let anyone leave you alone, during that process, because, and then I'll tell them my little story of, when you're in transition and baby's crowning, you will think that you can't do it and you'll just want to go home. Like, I can't do this.
Yep.
And of course it's not an option.
Right.
You're doing
point,
it.
There's no turning back.
Right. It's happening. Okay. Their head is going out, but you think in your mind, I'm not going to survive. The pain is so great. I can't do it.
Yep.
And that's when the advocate is there to help you. And endo is no different. Like, you have to have an advocate, somebody who believes you, someone who can remind you, yes, you were in that much pain,
right?
And we're going to do this together. You're going to believe yourself. I believe you, and we'll get to the other side.
Yeah. I have that too with patients that they're in so much pain, especially, well, really anyone. And they're like, take it out, take it all out, take it out tomorrow. Everything is hurting me. I want all my organs gone. And it is, and I'm very much of a huge advocate of women making decisions for themselves, but, kind of trying to get in a better headspace where we can talk about what is actually the cause of the pain. It's not necessarily your organs. It's the endometriosis outside of your organs.
Yeah.
It's not, adenomyosis can cause uterine pain, but the hysterectomy does not treat endometriosis. And trying to just, have a more rational decision with them and let them know that I hear them, I understand them, and I'm going to help them. But we don't necessarily have to castrate you or to take away your hormones to give you benefit. And then we talk about, I saw on your podcast with Megan and Dr. Wasson, the importance of estrogen and, going through kind of this long discussion, like, I'm here to help you and I hear you, and let's make a decision together, because this is a marathon, not a sprint. And, we can find, sometimes that is the answer, the hysterectomy, but frequently, the estrogen and the ovaries have so much benefit for us. I'm an ovary saver. Some people say, man, she's got guts. I'm like, she's got big ovaries. Like, let's support those, because there's just, there's not just for fertility, but there's so many longevity benefits for our estrogen and our hormones. And there's probably benefits that we don't even know, besides just bone health and cardiac health, but the longevity benefits, I'm even hesitant to remove ovaries when they're postmenopausal because they're still secreting a small amount of testosterone, a small amount of hormones. And so just having these discussions about advocacy, but also when they're in this, immense pain, trying to, have discussions on what next steps, we can take before getting to kind of the extreme steps.
Yeah. So when we talk about symptoms, because that's when you mentioned the, being mistaken for typical appendicitis or presenting like typical appendicitis, that is probably, just like in my case, that was the easiest thing for them to finally land on once they realized that, okay, well, even though she had appendicitis and an appendectomy before, they did the same thing again. What are some of the typical or atypical symptoms that you see of appendix endometriosis?
Yeah.
How is it mistaken for, oh, you just have gastric, upset, or some kind of other abdominal condition?
Yeah. So appendicitis or endometriosis, when it's on the appendix, does, like, classically is that right lower quadrant pain. The pain can radiate down into your groin, like down into your like labia, down your middle thigh. It can also radiate to your belly button. So sometimes you have some radiating pain there. It does classically tend to be exacerbated with your cycle, just kind of like dysmenorrhea, like early endometriosis. The classic presentation is, so you have worsening pain on this right side during your cycle, even women that are, taking medication, which with their amenorrheic, they may still feel some of this like ovulation, or they may still feel some of these fluctuations. Like if they have like a Mirena IUD, for example, they're not bleeding, but they may still have, hormone fluctuations, and you may still feel that right lower quadrant pain. Other people, sometimes it's hard to tease out, well, what is just specific to endometriosis and what is just, the appendix, but chronic constipation, pain with bowel movements, ovulation pain, whether it's right or left, ovulation in the general population may be uncomfortable, but it really shouldn't be painful. You're like, oh, I'm ovulating today. But endometriosis causes this hypersensitivity. Since everything is so inflamed already, it doesn't take much, even just a small cyst formation on the ovary, to push you over the edge. And so pain with ovulation, because the ovary, again, is so close in proximity. I've had one patient in my career who actually did not have endometriosis. She just had chronic appendicitis. And again, nobody would listen to her. And she had been to the ER multiple times. She finally came to see me, and I talked to her about, it was very classic pain, but she'd had multiple CT scans that were normal. And so they let her be. And when we went in for surgery, it was actually just chronic appendicitis. And we were both surprised. I was actually surprised that there was an endo, but she'd been dealing with it for 6 months. And those were kind of her classic symptoms. But pain on the right side, it was still exacerbated on her cycle, but I think it was just more related to inflammation of the pelvis, maybe with a little bit of like retrograde menstruation, the blood. Even though that's not how we think endometriosis spreads, women do have some retrograde menstruation, which contributes to the bloating, and like the blood is just caustic and irritating to the pelvis. We think that that's why women tend to have more like diarrhea or looser stools, during their cycle, because some of that blood is irritating the bowels and kind of causing it to go faster. We don't know everything, but these are some of the theories. But endometriosis affects the appendix about 30% of the time in women with stage 4 or stage 3 and 4, kind of the higher stages of endometriosis. But sometimes I see it independently. Down in the pelvis, it's mostly stage 1, but there it is on the appendix. And so if you don't look for it, you're going to miss it. And so it's important to make sure that we're very thorough, really, with every case. I'm a little type A. We do the same thing every time for at least evaluation of the pelvis, diaphragm, gallbladder, liver. We run the whole small intestine, and then we find that appendix before we look down into the pelvis, because frequently it's missed. And if we leave endometriosis behind, you don't get to reset. If we leave it on the appendix, but we clean it out of the pelvis, it's still there. So it not only comes right back, it technically was never gone. So it's really important to evaluate that and feel comfortable with appendectomies, kind of complex appendectomies, or at least having somebody else that can come in and do it for you. if you don't feel comfortable.
Yeah. Yeah. And I appreciate you making the kind of the classic presentation case, because that is how patients can self-gaslight again, because they can pass it off for months of, oh, it's ovulation pain, I'm about to start my period.
Right.
And I'm not an exclusion. I'm not unique in that way, because what did I do to myself the night before I ended up in the hospital? Oh, I'm about to start my period. This is terrible. I can only lay
Yeah.
on my left side. I can't touch my stomach at all. This is terrible. It's just another cycle.
Yeah. Yeah. You're not alone.
Yeah. So pretty classic if you have those symptoms. Those are good red flags to pay attention to. And you have a little extra point to consider, which, in medical jargon, we call it differential diagnosis, but
Right.
that's an extra variable to consider if you are in that situation and you have repeated pain in the lower right abdominal area around the hip, or like you said, hip pain, or vaginal pain, or umbilical pain.
Right. Endo, I say this in my clinic, endo doesn't follow the rules, which makes it sometimes so difficult to diagnose. So these are the classic symptoms of endometriosis on the appendix, but it is certainly not the only symptoms, and it's not how everybody is going to present. And so, we were talking earlier about, the whole body implications of endometriosis, but endometriosis on the appendix can also be that way. Sometimes people actually really don't have any symptoms of endo on the appendix, and we go in and it's just littered with it. And vice versa, people have very mild symptoms like ovulatory pain, or occasional pain that radiates to their belly button, or sometimes pain that goes up the right side, which is a little less common, but I do see that. And so it's always a surprise. Patients, I love surgery days. One, because I feel, I feel like I make, big positive impacts in women with surgery, but also I want to see what's going on. Mm-hmm. Like I'm invested in your story. I hear your symptoms. I want to see if your symptoms mirror what we find. And I want to see where it is. I want to see how much is in there. I want to see if it's on your appendix, because when I meet patients, I sort of map out in my head where I think it's going to be, based on these symptoms. Maybe this is where it is, or she probably has it on her colon or more on her appendix. And sometimes I'm right. Sometimes it still surprises me. So for me, it is just as exciting as it is for them to go in and see what we're going to find, and how much endometriosis is there, and where is it located. And, if your pain is more on your left side, do you end up having more endo on your left side? It's fun for me, but it's also still surprising how endometriosis affects women so differently, and why for some women it's really aggressive. At 16, they have stage 4 disease, and other women, it's still stage 1 when they're in their 40s. It doesn't mean that it causes any less pain or any less long-term sequela, but why the disease itself is more aggressive for some than others. And it's something that I'm still trying to learn with my practice and advocate for more research for, because, if we could find other options outside of just hormones, I think that would be just huge for this population.
Yeah. I was talking to Dr. Shanti Moling in another podcast. So if y'all haven't heard that one, go back and listen to it, because it's on the gut microbiome.
Yeah.
And that's such a promising area, because I've been looking at GI maps and referring for GI map testing, more comprehensive testing for, gastrointestinal health.
Right.
And I'm starting to see patterns in patients with endo of having low global commensal, the good bacteria, right?
Right.
Or they have high levels of things that we know can impact the way estrogen is metabolized.
Yes.
Really fascinating stuff. And I think those are the questions of the future too. Like, how else can we help mitigate this? Because like you said, I love that phrase, endo doesn't follow the rules. Right. And of course we need more research on it, but that could be one of the many, I think, future things to, investigate on how we can mitigate and mediate and help them to manage their pain and to not lose any more organs.
Yeah, I agree with you. And research at this true cellular level, I think is going to be key. And Shanti I listened to her lecture about this last year, actually.
Yes,
and
yes.
it is intriguing. And her hospital system is really invested in this. And I think it is, it's groundbreaking, and I'm looking forward to seeing, some of these outcomes and changes. And it is going to take time. Endo is really difficult because there's not specific genes that we can target that are only endometriosis. A lot of these other genes affect many different systems in our body, whether it's inflammation or hormone regulation. And so trying to tease out, even at a, not just genes, but even at a lower, like more molecular level, like proteins, and trying to even narrow down further, ways that we can try to, inhibit the growth of this disease, or at least catch it early. Wouldn't it be wonderful if there was a way outside of surgery that we could truly get, a diagnosis without having to, for, more invasive treatments? I love surgery. I'm a surgeon. I feel like it helps a lot of women, but it's a big decision. And if I could give more concrete evidence or better insight to help a patient make their decision, if this is the right next step for them, that would also be life-changing for many people.
Because I think about the cases that I see, the stories that I listen to of women with endometriosis, and some of their symptoms begin at puberty, and it goes from there. But I also hear, and I'm probably one of those, where I think about, what about I think I was 2 or 3 years old when I had that first appendectomy.
Right.
What was there then? What was happening then that my body already had created this inflammatory firestorm?
Yeah.
Was it there then?
Yeah.
Could we one day identify that in the 2-year-old and the 3-year-old and prevent a lifetime of pain and thousands and thousands and thousands of dollars, spent losing various organs, to surgery?
Yeah, I'm with you 100%. And I mean, I do think that it's likely the case. I mean, we don't know for sure all the etiology of the underlying, but, I kind of theorize that, the endometriosis implants, like, even when we're in your utero. So these cells may have been there. They just don't tend to be visible until you get to puberty and your body starts making estrogen, but they're likely still there. At least that's sort of the theory that I follow. But we don't know everything about endo. But it'd be lovely if we could catch it even before puberty, before a woman has to start to experience these symptoms, or at least early. But I think it is coming. It's just going to take some time, and certainly we're going to have to put some resources into women's research, which is hurting right now. But we'll work on it.
More than $2 per patient per year, at NIH, which may actually not be happening. We're not even sure about that. Right. But far more than that, when, as I've said before, but if for the listener, you haven't heard on other, podcasts, if I think it's $60 per person per year for diabetes, which has the same incidence rate of endo.
Right.
And everybody knows about diabetes, and no one really knows about endo, and we get no funding for it whatsoever.
No funding. And honestly, it goes back generations, because it's a female disease, mostly a female disease. And it hasn't been taken seriously, and it really hasn't been prioritized because I do think because it mostly just affects women, and it's very disheartening. But with your advocacy, with the advocacy from other endometriosis resources, we are going to get there. You just have to speak about it, and nobody wants to talk about it. Nobody wants to talk about being in pain or having painful periods or not being able to have, intimacy with your partner. Over cocktails, that's not what you want to talk about.
Constipation over cocktails.
Yeah. But, it is so important to try, at least in the professional space, to let people know they're not alone. You are not alone. There are many other people that are suffering just similar symptoms to you. And social media, certainly has its positives and negatives. But one thing that has been so helpful with it is the advocacy for endometriosis, and women being able to find groups of people that have symptoms similar to them, learning about endo, and then also being able to find treatment options. Most of my referrals are from social media.
Wow.
They rather find their friends on social media, or they get into some of these endometriosis groups, some of the big ones, some of the smaller ones, and they realize they start to learn more about endometriosis, learn about treatment options, but a lot of them have done it themselves, like self-advocacy. I do get some referrals, of course, but still the majority of my patients are from social media. And love it or hate it, there is certainly some benefits to advocacy and education if you're looking in the right places.
I can definitely, echo that. I think 10 years ago, it might have been a website. But when you look at the stats, and I can echo the same thing. I get some referrals, but most of it is through social media, specifically things like YouTube.
Yeah. And it's a great resource. And most of the time, the education out there is accurate, at least if you're looking in some of the right places. But even if the information is slightly skewed, at least they're learning more about it and looking for treatment plans and treatment options. And that's the start.
It translates to hope for people, because they hear about it. Even if you said, like, even if it's maybe not totally on, they will then realize, oh my gosh, I didn't know that what I thought was a bad period actually could be, endo or appendix endo, or any of those things. So I have go ahead.
No, go ahead.
Oh, well, I have a technical question about, because from a single cell perspective, we always want to like get the endo, right? You're in there and looking for it. And I think that's why many surgeons, and you can echo in on this, will not want them to be on estrogen suppressing birth control, that kind of thing, before surgery, because they don't want the lesions to be smaller and have something missed. But I think my question really relates to, it's along those lines of, what about, meds and estrogen suppression before surgery? What do you recommend? And do you generally go ahead and take an appendix out during excision to be sure? Or what do you think?
So, hormones are not wrong. They're just not for everyone. And so I think there's just this discussion of what hormones can do, what are the potential benefits, and then what are the potential side effects of taking these medications, and then letting the patient decide if it is right for them. Sometimes it's for fertility benefits. Sometimes it's just for pain benefits. And I think it's just important to have this discussion of not being afraid of hormones, but also understanding that it's not right for everyone. And in my practice, you don't have to try and fail every hormone before, we'll move to the next step. That if a simple, I don't feel comfortable with that in my body, that's fine. You don't have to, convince me that this is the right step for you. Just, again, trusting your instincts, knowing your body. A lot of my patients have gone a deep dive into hormones, supplements. Most of them have tried multiple. So as far as surgery goes, I actually don't have my patients come off of hormones before surgery, because the endometriosis, while it may change the way that it looks, it doesn't make it go away. So the cells are actually still there. It just may look a little bit more subtle. It may look like scar tissue, or like little clear blisters, or it may not be as big as it was before. However, I still get really wide margins around these areas. So I feel like it doesn't change outcomes, especially if it's helping with some of their symptoms. I don't want them to flare, immediately before surgery either. As far as the appendix, I do talk to them. I talk to them about like the potential microbiome or how it's helping some of the gut health. Younger women, so women less than 20, have more of a benefit from appendectomy. It's called an opportunistic appendectomy. And it's just because they have a higher risk of getting appendicitis, like related to endo or not related to endo. They have this higher risk because they're young. Younger people tend to have more appendicitis, or just throughout their lifespan. And so I talk to them about, what are your thoughts? With stage 3 or stage 4 endometriosis, I tend to move towards removal, because there can be microscopic. And there was a great study actually done. Who did this? I think it was done in California, but they removed appendixes in everyone, and then they looked microscopically to see how often they had endometriosis, whether they looked normal or not. And with stage 3 and 4 endometriosis, it was still 20 to 30% of appendixes that looked normal still came back with some microscopic endometriosis. And so with more advanced endometriosis, I do tend to lean towards remove it. But again, patient's autonomy. If they tell me, I don't want you to move any organ unless you absolutely have to, that's okay with me. We discuss the pros and cons. Doc, if it looks abnormal, remove it. But if it looks normal, I'd really like to keep it. That is okay. You get to make decisions about your body. And I go through all of these, what ifs before surgery, because when patients are asleep, they're my family. I mean, I don't let anybody come into that operating room that I wouldn't let operate on me. Like if I have other colorectal surgeon or somebody come in, and typically I make decisions as if they were my family, my sister, or myself. But sometimes their decisions are a little bit different than mine, and that's why I talk to them about it. What do you want me to do if this happens? What do you want me to do if this happens? What do you want me to do about the appendix? And so I always give a recommendation, but it doesn't mean that's what they have to do, because I truly believe in trusting your gut instinct and knowing your body, and everybody sometimes is a little bit different when it comes to that.
Yeah, I love that description of shared decision making.
Yeah, I try really hard, even in Texas. Women get to make decisions over their body, at least with me, at least during surgery, and just trying to give them just a little bit of power during surgery. You hear these terrible stories of women waking up with organs removed that they didn't consent to, or a hysterectomy when they weren't planning to, and I just want them to feel as comfortable as they can coming into surgery, that the decisions we decide before are going to hold fast during surgery. And of course we talk about the caveats to that, like if we find cancer or if there's so much bleeding we can't stop it, but that is incredibly rare, and in fact just doesn't really happen. So it's important for them to feel like they have at least some control and some say, even when they go to sleep, about what's being done to them while they're under.
Yeah, and that's like the most comforting thing to hear, because you have that seat at your table of your own care, right, which has historically not happened for women.
Right.
Yeah.
Yeah. And and it's not that hard to do. At their pre-op visit, we go through this, the what ifs. It probably takes 5-10 minutes, but it really does, I do think, makes a difference. But it also helps me feel more comfortable with what next steps are. So instead of just doing what I would do for myself or what I would do for my family, I have their input as well. And most of the time, 99% of the time, it's the same. If you just talk to your patient, you explain the pros and cons, but every once in a while they're a little different, and that's completely okay.
Yeah. And I think that speaks to the advocacy and education and kind of bigger picture, because that's the way care should be practiced. I mean, that's the future of care now.
Yep.
So
we will get there slowly, but surely.
We will. So I have one final question, and then I would love for you to share where everyone can find you.
Okay.
My last question is, what advice do you have for patients who suspect something is missed in their diagnosis, particularly when their pain has been dismissed or blamed on IBS, stress, anxiety, or just, oh, that's just a painful period?
Yeah. And we talked about this a little bit at the beginning, but a lot of women have seen multiple specialists, GI doctors, urologists, even seen OBGYNs. Endometriosis is very much of a whole body disease. It affects all of these different organ systems, your bowel, your bladder. Yes, it can, affect your reproductive systems, but your pelvic floor, your nerves. Advocating for yourself, trying to learn more about the diseases that you've been diagnosed with, but frequently, especially when it comes to women and young women, endometriosis is kind of the underlying cause affecting all these different systems. And certainly you can have multiple diagnoses. You can have IC and also endo, but frequently it is related to an underlying etiology, and trying to tie it all together. Endometriosis specialists are going to be a good place to start, because they sort of understand how these organ systems, intertwine, like how these different symptoms that you're having, which you may not think, like the chest pain, or while you may not think it's related to endometriosis, finding someone that understands these connections to help you with next steps. I actually think physical therapists, because they understand the pelvic floor so much. And a lot of times when they finally get to pelvic floor PT, a lot of times they have seen a lot of these other other
Yeah.
specialists. And so I think that is a huge resource, even to talk to. And a lot of the referrals I get, outside of social media are physical therapists, because they're seeing my patient every week. They're having discussions with them. They start to trust them. It's sometimes an intimate, exam. So you feel very safe and comfortable with your physical therapist. But just talking to someone about it, but ultimately seeing someone that really understands endometriosis, they can help you with kind of guidance on how to treat this as a whole, as a holistic approach, not just a one size fits all. Because, like I said, endo doesn't follow the rules, so not everybody has the same symptoms. Not everybody's, endometriosis, story is the same. And so finding a treatment plan that really works for you and focuses on sort of what your goals are, I think is really important.
Yeah, well said, and a great way to finish in talking about all those green flags, that you have someone, a practitioner that you can trust and that you don't mind talking to about diarrhea or constipation.
Right, right. I mean, again, nobody wants to talk about this over cocktails, but it's important. It's important. At some
Yep.
point, you need to talk to somebody about some of these symptoms.
Yeah, absolutely. Thank you, Dr. Rachael Haverland, for being with us. And where can everyone find you?
Yeah. Well, thank you, Ginger, for having me. This has been, this is great. I could talk about endo truly all day. I mean, just get me going.
We'll do it
um,
again.
but I am in Dallas. So we started Endometriosis Center of Excellence. Endoexcellencecenter.com is our website. And then I'm on Instagram at Texas Endosurgeon, and Endo Center of Excellence on Instagram too, and Facebook. But we're available. You can reach us online. You can call us. You can even reach out to me on Instagram, and I can get you set up. But it is a space that needs more practitioners and needs more advocates. Rather it's in the research space or it's in the physician space, or but it's coming. It really is, and even I've seen it change in the last 7 years. And there's big changes, and I think that it's going to continue to kind of grow and extrapolate. And so I can't wait to see, in 10, 15 years, how this endo space and the treatment plans for endo has changed.
Yeah. Thank you so much for bringing this hope onto the podcast today, and for all the work you do.
Yeah. Thank you, Ginger, for having me. It was an honor.